Preventing Diabetes. Part 1. Disease burden of diabetes on society. Diabetes is a major health problem worldwide. There were about 415 million diabetes patients in 2015, that is 62 million in India. By 2030, there will be 85 million diabetes persons in India. By 2040, there will be 640 million diabetics world over. All of these statistics likely are underestimates. 3/4 of diabetics live in poor and middle income countries. 80% of the global death rates associated with chronic diseases are in low and middle income countries. Diabetes is a major contributor to this mortality, that is death rate. Type 2 diabetes is associated with twofold excess death rate from cardiovascular diseases, devastating microvascular complications affecting eyes, kidneys, and nerves, as well as significant associated diseases including infections and psychosocial distress. If left untreated, the small vessel, that is microvascular complications, will ultimately lead to blindness, kidney failure, foot ulcers, and amputations. Diabetic disease burden entails serious social and financial impact because of blindness, dialysis, and amputations, etc. Advancement in drugs and knowledge about the benefit of physical activity, control of overeating, stopping smoking, reducing blood pressure and lipids, as well as lowering glucose have definitely been encouraging. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Causative factors for increase in diabetes patients. The exponential increase in the number of diabetic patients is due to many factors. Cable TV. Sitting on the backsides for umpteen hours in children, cartoons, games, mobiles and cricket, housewives, family serials, cinema, adults, cinema and cricket. Economic betterment and more money to spend, that is buying more processed food and fast food. Urbanization, causing increased opportunity and better paying jobs in urban areas and thereby entailing reduced physical activity. Mobile phones and computers. Increased life expectancy. Average life expectancy in 1980 was 56 years. In 2016, it is 69 years. Low birth weight children. Low birth weight children are born more to economically poor mothers. Low birth weight predisposes to diabetes. These low birth weight children may also have diabetes in pregnancy when they grow up. If it is poorly controlled during pregnancy, the risk of their offspring getting diabetes is more. Poor people eating more carbohydrate and fat-rich foods. There is a tendency among the poor people to take more carbohydrate and fat-rich food since it is cheaper than foods lower in calories containing antioxidants and vitamins. Plant-based foods are the best sources of antioxidants. These include fruits, vegetables, whole grains, nuts, seeds, herbs and spices, and even cocoa, that is chocolate. Fruits, vegetables and whole grains, high in antioxidants, are also typically high in fiber, low in saturated fat and cholesterol, and are good sources of vitamins and minerals. The sources of antioxidants and fiber and low fat and cholesterol, all these are slightly costly. So, the socio-economically deprived have a greater tendency to gain weight by taking cheaper carbohydrate and fat-rich food. Antioxidants. Note: antioxidants are compounds that inhibit oxidation, a chemical reaction that can produce free radicals that may damage the cells of organisms. Antioxidants scavenge free radicals from the body cells and prevent or reduce the damage caused by oxidation. Antioxidants such as ascorbic acid, that is vitamin C, may act to inhibit these reactions. To balance oxidative stress, organisms contain and produce antioxidants such as glutathione. The only dietary antioxidants are vitamins A, C and E. A diet high in antioxidants may reduce the risk of many diseases, including heart disease and certain cancers. Vitamin D deficiency. Sun exposure aids production of vitamin D by skin. Vitamin D deficiency is associated with insulin resistance. If sun exposure is avoided for occupational, that is white collar jobs, cosmetic, I'll become black if I expose myself to sunlight, which is a misconception. Convenience, no time to walk to office, even half a kilometer away. Laziness and false ego. What will people think if I walk on the road? Are some of the reasons for people avoiding sunlight. Peripheral neuropathy. Damage to nerves by diabetes is a very common cause of peripheral neuropathy. 15% of diabetics have peripheral neuropathy. 3 to 4% of diabetics have amputations, at least a single toe. This means that at least 1.5 million of the 70 million diabetics in India alone have at least a toe removed. This impairs their morale, their physical balance for walking, and if a laborer, their ability to earn for their daily existence may be hampered. School health program. Pre-diabetes, that is fasting blood sugar of more than 100 mg per deciliter, is present in 20% or more of high school children. They have more subcutaneous fat, thick skin as compared to their daily other classmates. This is a strong signal for proper focus on school health program to prevent obesity, diabetes and abnormalities of cholesterol which wreak havoc on the children when they become adults. Compulsory physical training and games during school hours must be enforced, which can avoid 80 million people or more from falling sick in the ensuing 40 years from now. Now, we will consider other preventable strategies for diabetes. Obesity. About 80% of patients with type 2 diabetes are obese, as are at least 30% of those with type 1 disease. Obesity is one of the greatest obstacles to successful management of diabetes. Obesity worsens insulin resistance. More weight means more insulin resistance. Obesity worsens dyslipidemia. That is, more weight means more triglycerides and LDL lipoproteins in blood. Obesity worsens hypertension. More weight means higher blood pressure. Obesity is an important risk factor for coronary heart disease, CHD. Even 10% weight loss in obese persons decrease fasting blood glucose and reduces requirements of anti-diabetic drugs including insulin. There may also be variable improvements in blood pressure and dyslipidemia, that is, decreased triglycerides and bad low density lipoprotein cholesterol, and increased good high density lipoprotein. The notion of the diabetic diet must now finally be laid to rest. Traditionally, carbohydrate intake was restricted, that is, restriction of wheat and rice. There was a simplistic assumption that sugar alone raised blood glucose and might even be diabetogenic. So, a high fat intake was advised that undoubtedly helped to sustain obesity and probably predisposed to atheroma. Current advice is that it is close to the healthy eating recommendations for the normal population. In other words, patients need not have a special diet and can have the menu items that is served for the rest of the family. Reducing total energy intake. Fats. Reduce fat intake. Fat-rich foods have the highest energy density, that is 9 calories per gram. They also have poor satiating effects and so tend to encourage overeating. Carbohydrate and proteins have energy density of only 4 calories per gram. The initial target should be a 10% loss of starting weight. A 10% weight reduction to be effective in terms of actual weight loss may take several months. Weight loss by a small but tolerable change in lifestyle, that is diet restriction and mild exercise, is much more likely to be maintained than weight lost by crash diet and rigorous exercise. Sudden and enforced severe starvation in the hope of achieving rapid reduction in weight cannot be sustained over a long time, bound to fail, and is not practical. Instead of portions, a thumb rule of advice is to reduce 1/8 of what one has been eating, which is more practical and easy to follow. For example, if 4 slices of bread is the usual quantity taken, reduce to 3.5 slices. If 4 idlis, rice pancakes, is the usual quota, take 3.5 idlis. Likewise, for meals, reduce by 2 tablespoons full of cooked rice or quarter or half of a chapati, that is roti. After 3 weeks, when the body gets adjusted to the reduced quantity, reduce another 1/8 of the previous quantity. Another seemingly silly but very important rule is that Every mouthful of food should be significantly small portion of food. Example, if it is idli, make a minimum of 6 pieces of one idli and take one by one with the preferred side dishes. If it is chapati or roti, make at least 10 pieces of one chapati and eat one piece at a time. Go on munching it intentionally slowly for a minimum of 25 times. Yes, 25 times. And then only swallow. By that time, the food would have become an almost watery paste with plenty of salivary juice mixed and may even taste sweet. This way, you will take a minimum of 15 minutes to finish your breakfast and another 15 minutes to complete your lunch or dinner. The usual habit of taking major meals at great speeds, taking only 5 to 7 minutes, is very, very wrong. By rapidly finishing off your meals, you tend to overeat as your satiety centers in the brain take time to get satisfied. By eating slowly, you give time for your brain centers to get satiated. All this discipline at meal times will have positive results. Try to reduce very small quantities of food every 3 weeks only. Eat substantial quantities of vegetables. Generally, they are low calorie dense. Include fruits in your daily food timetable in moderation. Include whichever fruit is desired, in season and cheap. In between major meals, whenever hunger pangs urge you to take some food, prefer low calorie fruits, avoid ready-made fruit juices than high calorie fried snacks. As weight falls, resting energy expenditure also declines because resting energy requirements depend on body weight. A leaner person needs lesser energy at rest than an obese person at the same dietary levels. Initially, the body weight may decrease more. Later, as the body weight becomes less, the same amount of food may result in lesser body weight decrease or maintain even the same body weight. Hence, dietary quantities may have to be carefully reduced and exercise mildly increased. Please note that months of careful dietary restrictions may easily be compensated by a few days of careless overeating. Fat should provide less than 15 to 30% of total energy intake. At present, in most industrialized countries, it accounts for 40%. Polyunsaturated oils, example sunflower oil, or monounsaturated oils, example olive oil, are preferred to saturated animal fats. Ideally, animal fats should be avoided altogether. At the very maximum, they should comprise less than 10% of total energy intake. The lesser, the better. Vegetable oils are better than animal fats, even though all types of fats or oils have the same energy density, that is 9 calories per gram, and therefore equally obesity maintaining. In general, eat non-vegetarian foods including eggs as less as possible. Dear listeners, this is the end of part 1 of the discussion. For part 2, see the video Diabetes Prevention part 2 of this series.